So thank you very much indeed for inviting me. I will try and tailor the talk to be a bit different from everyone else, so that might mean gliding over a few slides at the start. Declarations at the start. Sepsis bad. I think we've probably been through that. Blood culture is good, need to use the right antibiotics. Reason for having this up, lots of reports, and lots of reports out, including O'Neill's, etc., etc. Rapid diagnostics is an important part of dealing with this. And clearly you want to make diagnosis very quick, and again, as O'Neill pointed out, lots of people dying of antibiotic resistance by mid this century. Reason I put this one on is as a reminder to myself that you can't do everything. Now, if you think about the amount of people who get treated with IV antibiotics with suspected sepsis and get a blood culture sent to us, actually the majority that we're getting are going to be negative. We may be slightly worse amongst ourselves, but we're about 7%, literature's 5 to 10. That means that 95 to 90% of all antibiotics are not going to be affected by this. However, I'm not trying to talk this down, and we do a lot of work on this. This is kind of where the homework started. Busy slide straight out of, I think this is Stata. What this basically said is, this is when we first started looking at it, we started counting the amount of time. So we looked at the pathway of a blood culture coming out of someone's arm, into the bottle, into our lab. Ping comes positive, eventually you end up with a sensitivity result. And what we ended up finding was the amount of time to make the machine go ping was 19 hours. The amount of time that it took us to get the sensitivity result was 19 hours. So these are the areas that we wanted to look at. And this is the one I'm concentrating on today, which is the amount of time it takes to get the antibiotic sensitivity result. This is our basic pathway, which is going to be very similar to most people. So just to talk you through it, bottle gets taken, gets into, we use the BD Bactec. Either it's negative or it signals positive. The way that we're running it and have been running it on this is the first thing you do, the machine pings, is it goes, before you even think or do a gram stain, it goes onto a blood plate, gets incubated. Then you start doing your grams and doing everything, ring up based on your gram stain. 4 hours later, that goes on to that, you just get any growth that's on there, goes straight onto a moldy, and we get a moldy result in our hands, 90-ish% at that point, maybe a bit more for gram negs. Subculture, and then we do the, again, we're a BD lab, so it's a Phoenix there. And again, this is taking our 48 hours-ish to get that in a sort of traditional way of running. So I've got 3 parts to this talk, and they're focusing mainly on the rapidity of diagnostics. The technology is I'm slightly neutral about, but we use the Alfred from Halifax. So what we did is, again, you saw earlier, I'll show you some data on just making sure it does what it says on the tin and does work like we wanted it to. Survey of the clinical impact of these results, and a service review after we introduced the Halifax. So what this does is normal pathway, but what you do is you have a rapid, so as was described earlier, get the thing out, do a gram stain, and then you put a result onto this Alfred machine and you get a result in about 6 hours. So that's what we're trying to do in order to speed things up, so to reduce from hopefully 48, so take off another 16 hours-ish off that, get a result quicker. And so what I'm trying to do is look at whether it works, what difference it makes, and what happens when we put it in. Again, I'll briefly elide over this because it's been looked at by a number of people before, but you can do phenotypic or genotypic resistance typing. Personally, I'm a big fan of phenotypic and not of genotypic. I won't go into that entirely here, but there are a number of ways of doing this. Broth microdilution, clearly it takes a long time and is tricky, but is the best one to do. Automated devices, and we use a Phoenix, and that's what we compared against mainly because it was a service evaluation and we weren't set up as a research study to compare with broth microdilution. And there are a number of newer techniques. You've heard about the PhenoAccelerate. Here, I'm going to let you know about another one. But there are a number of techniques which are looking at using phenotypic sensitivity. And there were 3 or 4 of these available at ECMID when I was wandering the hall in April. So what did we do? We used, this is our first one, so does it work? Does it do what it says on the tin? So we used the Alfred AST60. I'll go into a little bit as to how that works in a bit. We used the BD Phoenix, and we had an e-test to try and resolve any differences. We've got 405 isolates, which we're running through. This was not done in, for clinical impact. This was just to check if it worked. We had 387 valid, 301 gram negs, 86 gram pos. The reason for the imbalance is we got those kits a bit later. They were a bit longer to get. And to be honest with you, we were much more interested in doing the gram negs than the gram positives. And we looked at the time it took to results and the categorical agreement. This is the Alfred by a company called Halifax in North Italy. Funny way of naming things. It's about, fits on that desk, it's about that big. It's got a big door that you open up here, and then you've got these little vials inside. So effectively what you do is you get 30 microliters of blood straight off a blood culture that you know whether it's a gram positive or negative, put it in a vial, stick it in the machine there. The bugs grow, and you look at this with shining a laser through, and you get either diffusion or scatter, which you can measure just depending on where it is, and you get a nice graph like that over time, so 0 hours, 5 hours, and the thing grows. You have it first to incubate. Once it's got to effectively half a McFarland, you then have an arm that comes in automatically, takes out some and puts it into a series of vials with antibiotics in. You can set these antibiotics as to whatever you want. It's called a 60 because there are 60 vials, so you can do one organism with 60 different antibiotics or 60 organisms with one. It's quite configurable. We used about 8 in our panel. And what it then does is once they're in here, you do light scatter and absorbance over time, and you compare something with no antibiotics in to something with antibiotics in. You get a percentage growth. And then for most organisms, 5 hours. For some organisms, 3 hours, you get a result. So 1 plus 5 or 1 plus 3 gives you a 4 to 6 hour time for getting an antibiotic resistance result. It gives you SIR, so it doesn't give an MIC, so you get sensitive intermediate resistant. And the other thing it doesn't give you is an ID. So we run this in parallel with the moldy. Given the way that our moldies are done at 4 hours, we've got a result by the time that this is pinging at usually an hour or 2 after the moldy's gone. So rapid sensitivity testing within 4 or 6 hours. It doesn't do ID, doesn't do MIC, but is remarkably configurable. So here are the ones that we were doing. So 405, number of reasons for failures. We had relatively few polymicrobials. 301 gram neg, 86 gram pos. What you can see from here is that it's very quick. So it really does do it in 6-ish, 6-7 hours, as opposed to 2024 for the others. Here's the agreement. So again, we're looking at categorical agreement because this is only SIR, it's not MIC. Here you have the individual antibiotics that we're testing, firstly for gram negs, secondly for gram positives, number of AST results that we have, giving us an overall agreement of 95% with a Phoenix. There were some that were good and some that were bad. The gram positives did not fare particularly well, but clindamycin was a bit bad. We fed that back and that is being improved. There were also some problems with the aminoglycosides and with Cipro. Where's the Cipro gone? Cipro here, and aminoglycosides. The Cipro was partly around an issue with the UCAST changing its breakpoint that the software hadn't caught up with. So that has improved. And the amikacin, I think they've made a slight change to it, and that has improved. But as you can see, you've got relatively good agreement here. If you look at the different organisms, again, this is broken down by organism as opposed to that. Now, the last one was antibiotics. This is organisms. So you can see that amongst the gram-negatives, Proteus is a bit naughty, but there aren't that many isolates in there, so that might have been one or two having problems, but most of these are fine. Staph aureus, not brilliant. So again, our decision to concentrate on the gram-negatives seems to be borne out relatively well. Been through this several times, I'm sure, so looking at what you're doing, where is our benefit going to be? And again, it's, as was stated earlier, it's with the reducing this time of uncertainty. So you start off, you have your clinical illness, you get your empiric antibiotics. The way that we set them is we just look at a year's worth of data and go, it's got to be more than 90% sensitivity amongst all isolates in this hospital as to what our empiric therapy will be. Obviously gets twiddled with in individual patients. So you're going to be expecting the majority of these are going to be on the right antibiotics. You then get a result, narrow to more appropriate antibiotics, so start, smart, and focus. And so the main benefit is going to be, firstly, interacting with an ID or microbiologist to give some advice. The ID, you've actually got a bug there, you didn't start the patient, which does sometimes happen. And narrowing the focus here will tend to be. Still not 100% sure about all the factors influencing antibiotic decisions, which we'll come to a bit later. And you need to know that the technology is robust, we're relatively happy with that. Then what does it do? It is a bit complex because, you know, there are a whole series of things. You've got the host response, how are they doing? I'm not going to change this antibiotic or make it narrow spectrum because the patient's getting worse. Antibiotic bundles and exactly what we're being told to do this year by the DOH will vary in sequence and so on, so that will have an effect, and the pathogen itself will have an effect, and the outcomes that are going to have an effect. There is a tension which I think everyone in the country is feeling between what's appropriate and what's rapid. So surviving sepsis, you've got to be rapid, but you also don't want to give too many antibiotics that are broad spectrum and cause resistance. So it's keeping those in tension and being able to change. I suppose, again, this is putting the whole thing. So you arrive in ED, you get your workup, you start, you have empiric therapy. You hopefully, so this is how unwell you are. This is a nice course, so you get better. At some point along this course, hopefully as you're improving, you do get, oops, pressed the wrong button, some intervention. Clearly, if they get worse, then things change. But again, this is reason for this is just putting in the sort of complexity of the issue. The other thing is who's prescribing. We're not a black box. That immediately you come up with a result, it changes. There's a person at the end of that prescribing decision, which usually isn't me from the lab side, though I will give advice. So again, we wanted to look at how these change and what happens with that person. So after putting it again back into context, the kit seems to work. What difference do rapid results make? So this was a survey that we did earlier in this year, where we sent a survey around with basically 4 case scenarios. We asked some quick demographic questions. So what grade are you? How long have you been qualified for? What specialty are you? And then we gave some questions and we analysed the answers. So here's one 75-year-old woman comes in with urinary symptoms, 38 degrees, respiratory rate 20, blood pressure 100 on 55, gets started on kermoxiclav and amikacin. She then gets worse, and meropenem gets started because she's getting worse. I think this is said to be early one morning, this is the next day. We then come back with the results of a fully sensitive Proteus mirabilis. And I think this is it, yeah. We asked them what would they do, and you've got to choose one of these. So contact micro, contact your own consultant, wait for the next ward round, continue the marrow, de-escalate, and so on. So we grouped these questions into when a patient gets, so this clinical evolution, when they got better, when they got worse, when they got worse, when they got better, whether the antibiotic was sensitive, whether the bug that was grown was sensitive or resistant to the antibiotic, when the result was available, so whether it became available during office hours or out of hours, source of infection probably slightly less important. And the idea of this was to pull out how much of these were actually being affected by knowing what the antibiotic sensitivity result and how much wasn't. Classification, I'll come to this a bit later, so I'm going to dwell a little bit on this because it's a bit complex, particularly when you're doing like what we do and using an aminoglycoside plus another antibiotic, because the aminoglycoside is doing most of the lifting. And, we're organamycasin, that will kill 95, 96% of bugs. So you're not going to escalate very often, but what you can do is narrow down to stop the aminoglycoside. So what we've ended up defining is effective and non-effective, so whether it works or whether it doesn't work. But we've also looked at microbiologically optimal and suboptimal. And what that means is what we're defining as the most narrow spectrum antibiotic that will kill that bug. So here's a little example. Here's an E. coli that is resistant to amox, sensitive to ceftriaxone, sensitive to meropenem. Now, the amox is not effective and it's not optimal because it doesn't work and it's not much good, and therefore is suboptimal. The meropenem is effective, but it is a broader spectrum than the cephalosporin, so we would count it as effective but not optimal. And so in this small example, the optimal and effective antibiotics is ceftriaxone. So there will be other examples of this where we'll look at the number of those who are on effective antibiotics. That you don't make that many changes on that because, if you do 300, 400, 500 patients, you're only going to get 5, 10, 15 per 100, out of that whole group. 20, 30 are not going to be on effective antibiotics. You don't get much. But what you do get is whether you can effectively choose the optimal antibiotics. So we're going to do a bit of that, and we analysed whether people were asking for support. Took about 12 minutes to do. We had quite good completion rates online. It was done in a number of hospitals in London and in Barcelona, more people in London than Barcelona, mainly medics, 80% medical, and most of them senior, which I think we defined as 8 years after qualification, to compare between the two. Just to give you an idea of the flavour of this, I'm not going to go and dig into all the details, there is other stuff available. If you look at the 3 cases, so case 1, you had an improvement, 3 a deterioration improvement. If you look at choice of optimal versus suboptimal therapy, so you had where there was improvement and a sensitive bug, as in case 1, you did have quite a lot of people choosing the optimal, in inverted commas, so following what the micro told you. Not everyone. And where you had deteriorations, almost whether it was sensitive or not, which is case 3 and 4, you didn't have as much choice of optimal based on this survey. So clearly there are factors not related to what the machine says that are playing here. If you look at requests for support, again you have differences. Case 1, which was where patient getting better and sensitive, not many people wanted help. Goes up where patient getting worse, resistant, you had more requests for help. So there are differences that are completely unrelated. And in understanding these pathways are very, very important to know how to deploy it, where to deploy, and what to do with any tests that are doing this. This was optimal versus suboptimal, and again comparing the UK and Spain. So there were country differences. So not only the majority, the UK is in green, the Spain is in red, in orange. My words will get there. Middle age is a horrible thing. These were significant differences between. So regardless of what the exact thing is, there is something within the working way of working and working culture that is different, that isn't dependent on the results, and not necessarily dependent on the basis in the culture, is a game which needs to be understood. This was quite a blunt instrument, and I don't want to read too much into it, but what I wanted to do with this is just to show that this is an important area to look at and to understand how that patient pathway and that working pathway is affected. So conclusions, I think I've been through most of those. Just going on to now the service evaluation. So we deployed, after having validated it, we use and are using in anger our friend the Alfred in our laboratory. The way it works is, again, we've taken a pragmatic approach which is slightly different to Hampshire. What we decided was no one's going to do anything with this result after hours. The idea of trying to find someone and get them to change an antibiotic, which is it's likely to be sensitive to, is much less likely. So what we do is we put an Alfred run up between 7 and 8 in the morning, and we put an Alfred run up at up to 11, and then we don't do any after that. So we're getting them all within hours. What that means is you have a comparator group that aren't within hours. So anything that's pinging outside those times, we're not picking Alfred on, and we're just running it through a routine. The other thing to be clear of is that we have not changed our routine at all. So if you have an Alfred, you also get your Phoenix. The reasons for that are the full antibiotic sensitivities are important for deciding on what our empiric antibiotics and knowing what our epidemiology and antibiogram for our hospital is. And so we need to know that. So this is in addition, and it does not replace any of the stuff that we're doing. I think it should say 11, not 12. Maybe we started hoping it was at 12 and it changed it to 11. Go this later. Our clinical protocol is organ amikation, or at least it was at the time. And what we wanted to do was assess the effects that we had on the clinical outcome. So positive blood culture, it had to have gram-negative rods. We only did gram-negs. As I said earlier, we subculture and identify on a moldy. And if it was in the right time period, it had an Alfred done. This was given to, we've got a bank of registrars, so it would usually, we ran it completely with our normal mechanism, so it was usually registrars calling this out. They'd go to the clinician. Depending on which way the wind's blowing, they will go and see the patient or not, but there is a verbal consult with the, at least by phone with the attending physician. Again, carmoxyclav and amikacin are our routine antibiotics, go-to antibiotics for sepsis of unknown origin, UTI. Lower respiratory tract infection is benpen and doxy, and we get a number of other things between those. So inclusion criteria, kind of been through it, which is all ages. Most, I've listed the bacteria here that the Alfred will do. We included in the analysis, though clearly we gave a result for, we only included the first episode if they had a multibacterial or recurrent infection. There weren't many of those, but we removed those. We excluded where the blood culture was considered contaminant, which is not very common, and mixed cultures were excluded. We looked at several outcome measures as a part of this. So time to first appropriate antibiotic, time to effective antibiotic, time to de-escalation, and time to optimal antibiotic, microbiologically optimal antibiotic. We looked at process outcomes, so time to sensitivity and ringing to clinicians. We did look at all-cause mortality, and we looked at time to discharge in terms of that. So we had both prescribing, lab process outcomes, and clinical outcomes that we were looking at. How did we define escalation? We got this off a paper, and I can't remember the reference for it at the moment. I'd need to look it up. But we classed antibiotics in a list like this. I think you take any one and you can quibble with where something is. We just needed something that was had been used before and was at least reproducible. And we defined, as I said earlier, effective and optimal. So we're able to define effective, we're able to define optimal, and we've got an escalation ladder, which is what we're using there. This is now separate from this. This is in real time, deployed, being used in routine practice. 211 bacteria, 9 are excluded for a number of reasons. So repeat episode, a Kingella, it's not covered, anaerobes and polymicrobial that we didn't, it's leaving us 202 patients. Nicely, 102 in our Alfred rapid group, 100 in the conventional group. We get invalid results of those 100 from the Alfred in 4. In terms of the analysis, we excluded those that died before 4 hours because our assumption was it just wouldn't, nothing's going to make a difference if they die within 4 hours of the result becoming available. So that ends up giving us 98 in the Phoenix group, 93 in this group. Because this is different from the previous set, these are a bit later, we've included the agreement in terms of the very major errors here, and these are all gram-negative, so this is now the same thing as I showed you earlier from when we were deploying it, and again you can see when we've done it in this, the numbers are smaller so it might not be as good, but as you can see we've still got categorical agreement of well over 95% here with just one very major error in the Cipro group. And a couple of major errors. Again, it's not a reference standard necessarily, it's a BD Phoenix, but it is our go-to system in our lab. Baseline, am I doing for time? I'm still okay, aren't I? Baseline characteristics. So these are everyone that I haven't excluded so far, just to give you the baseline as they come in. Similar numbers of females, a couple of things that are different, but when you look at this many things, you do expect a few things to be different. Slightly more resistant organisms, so resistant to 3 groups of antibiotics, more common in the standard group than in the rapid group. Here's the antibiotics that they were, the resistance pattern is shown up here. Next slide is, again, these are baseline characteristics, slightly different CRP, slightly higher in the rapid group than in the other rapid group. Slightly lower PIT score of comorbidities here in the rapid group, a few more in intensive care on the standard group, but again, I'm not particularly worried about the balance. You do occasionally expect to see differences in the baseline characteristics. And again, if you look, most patients, these are basically out of 100, so most patients are on aminoglycosides, and then 30% on PIP-TAS, 30% on ORG, and carbapenems in about a quarter of them. They don't add up to 100 because they're on more than one antibiotic. So looking at the mean times here, these are the times from taking the blood culture to calling out a result, and you're going from 60-something hours to 40-something hours. So you are definitely reducing it by just adding this bit of kit into a lab. You can reduce the amount of time it takes you to call something out. We're early in the analysis, so we're still going through it. So these are not final analyses, but just to show you some of the things here. So the time to optimal therapy, so this is basically very similar to stopping aminoglycosides. So being able to stop aminoglycosides is significantly different. So here's the Alfred group, here's the conventional group, and so you are 32 versus 54 hours to be able to stop aminoglycosides in these groups. In terms of time to optimal therapy, again, this is lower, but again, it's a similar thing that you are being able to narrow down and stop an aminoglycoside. Effective escalation was again lower, but there's such a broad spread that it's difficult to read too much into that. And when we looked at multivariate logistic regression, at all the factors, the time to stop antibiotics, the time to stop aminoglycosides was still more rapid in this group. So you do appear to be having a robust effect from using it. When we looked at things like time to effective antibiotic, there was no difference, but because nearly all of them are on effective antibiotics when you're calling, and you're looking, I think I've got it on the next slide possibly, there was a subgroup who were not on effective antibiotics, and that was 23. So you have to do a very, very large study when you're looking at those kind of outcomes to to get an idea of what difference you'll be making in these. So on our 200 odd patients, it's difficult to see that. When you do look at these, clearly you do have you've got a better time for escalating within that. But most of the other things in terms of, sorry, I should be stressing, these are times from drug charts. They're not from ringing. We've got electronic drug chart system that we check. So this is, I can't guarantee when the nurse gives the thing, but it's when it gets written on a drug chart. So you are having these kind of effects. As I say, there's a relatively early set of data that we're going through. So no differences, but again, I suppose one wouldn't expect to find these. So 28-day mortality, no difference. Length of stay, no difference. Time to discharge, no difference. Time to effective antibiotic, no difference. For the whole group, when you narrow it down to those who didn't happen to be on it, you can find that kind of difference. Time to stopping all antibiotics. Use of broad spectrum, though that's a slightly tricky one to define. And ITU admissions were non-significantly higher in the standard group, but not reaching significance. So to summarize, because I'm 1 minute late and I'm really, really sorry, we did, if we've got epidemiology to guide our local guidelines and empiric treatment, we've got expert prescribers. The laboratory can, changing the workflow like this, can make a difference, as we can see from this very early, but we do need to understand how the processes are working in order to guide this and work it best. So one side doesn't fit all, or if you're issuing a result. And I think, though exciting, we do need to know a little bit more. Thanks. I'd like to thank Vanessa Anton, who did the vast majority of this work, who is an MD student who is just doing clinical at the moment. Otherwise, she'd be here. And say thank you very much, and any questions.